Welcome. I'm Rachel Lessem, a research scientist from the Leonard Shanfield Research Institute at CJE Senior Life in Chicago. I'm so happy you all could join us today. First, some housekeeping items. This webinar is being recorded. Please stay mute until the Q&A. If questions come up during the presentation, you can put them in the chat box. Second, any tech issues, please also put them in the chat box, and my colleague Christine Norick will answer them. Stay tuned for 2 more webinars in February and March, which you may already have registered for when you registered for today, and an evaluation at the very end, which you will also receive in an email sent to the email you used to register for today's webinar. This webinar is funded by the Patient-Centered Outcomes Research Institute as part of their initiative to accelerate tools and resources. So let's get started. We have divided the 4 webinars in this series based on the timeline of a SAGE model board. Our last webinar, which you can view on our website, was a general overview. Today is about building a board. Next webinar, the 3rd one, will be about operating the board, and the final webinar will be about evaluating a board. During today's seminar, you'll become familiar with strategies for selecting providers of long-term services and supports to partner with to create SAGE model advisory boards. You'll consider the capacities and needs of providers for building research advisory boards. You'll be able to identify core principles for building these partnerships. And finally, you'll understand approaches for recruiting older adults as advisory board members in different settings. So to start off, what do we mean by engaged research? In talking about the SAGE model in particular, we mean working collaboratively or seeking knowledge from those who have a direct stake in your research to ensure that the research findings are translatable and that they lead to solutions to recognized problems. So what is the SAGE model? It is a standing and ongoing research advisory board comprised of older adults who operate as SAGEs, offering guidance from the expertise of their lived experience receiving long-term services or supports or similar populations. It is based on a partnership between an academic partner and an LTSS provider in an ongoing reciprocal relationship. And this partnership, the SAGE model board, is guided by the PCORI principles of engagement, meaning reciprocal relationships, co-learning, partnership, trust, transparency, and honesty. And in contrast to community-based participatory research, for example, these standing advisory boards, these SAGE model boards, are not tied to a single project, but rather the SAGEs continue to give their input on multiple projects to multiple researchers at multiple stages in the research. And the ultimate result is engaged research and greater research success. The SAGE model is a flexible approach that allows us to say all research can and should be engaged research. And it has been designed for people who may not be active agers, who are the typical people who are targeted for engaged research. So the goal of the SAGE model board is to embed engagement into the research process, whether it's the next topic of study, designing your study, refining your proposal, and demonstrating to your funder that you have stakeholder input for relevance of your study, addressing issues that arise during implementation, analyzing your data and results and interpreting them based on the SAGE's lived experience, or dissemination strategies, because the ultimate goal is having your research have real-world implications. And dissemination and application beyond peer review. Another trend among funders and government research institutes is a push for public summaries that can be consumed by diverse target groups, expanding knowledge and application. And you can extend your dissemination reach by sharing with these communities, who also may help advocate for the application of findings and additional research funding to investigate new questions. do we mean by academic partners? On this slide are the logos of the academic partners who have, in our previous project, SAGEs in Every Setting, worked to expand the number of SAGE model boards. So first you can see CJE Senior Life. This is the Leonard Shanfield Research Institute at CJE, which is a research department focused on applied research and is housed within a social service agency that addresses a continuum of care for older adults and their caregivers, from living in the community all the way to skilled nursing. There's the Leading Age LTSS Center at UMass Boston, which combines the resources of a major research university with expertise and experience of applied researchers who work with providers of long-term services and supports. We also had the Mesalem Center, which, like CJE's, was both the academic partner and the provider partner. The Mesalem Center for Cognitive Neurology and Alzheimer's Disease at Northwestern University's Feinberg School of Medicine provides quality care to its patients while also conducting research on how the brain coordinates mental functions and transfers the benefits of that research directly to patients while preparing future scientists and clinicians. And finally, we have the Miami University of Ohio Scripps Center for Gerontology, which is also a research center at a major university, which conducts a wide range of aging-related research in areas that include demography, long-term care, program evaluation, the workforce, the aging workforce, and dementia programming, with 19 staff and 20 affiliated faculty. So what does an academic partner do as part of a SAGE model board? Well, first and foremost, it finds a provider to partner with and then establishes and formalizes that partnership by explaining the concept of the SAGE model, identifying gatekeepers and champions in the provider setting, developing trusting relationships, and clarifying the roles and responsibilities and time commitments. The academic provider also collaborates with the provider. The academic partner also collaborates with the provider in planning and implementing the SAGE model board by providing orientation, support, and resources for members, training or assisting with training members, and connecting the board with researchers who wish to present their research. And finally, conducting or assisting with the evaluation of the SAGE model board. And by this, we really mean a process evaluation rather than an outcomes-focused evaluation. I'm really pleased to welcome our first guest speaker, Katherine Abbott, who is Associate Professor at Miami University of Ohio, Research Fellow with the Scripps Gerontology Center, and was also our partner in the SAGEs in Every Setting project, which was also funded by PCORI, in which we worked on increasing the number of SAGE model boards through these partnerships. Go ahead, Katie.
Thank you, Rachel. Can you hear me okay?
I can hear you just fine.
Awesome. And so I want to say hello, everybody. I'm going to look over here because my slides are here, but my notes are in front of me. So I apologize for that. And really delighted, really appreciative, Rachel, for inviting me to be a part of this webinar and a part of the study where we developed a couple of research advisory boards where we tried. And yeah, Miami University in Ohio, it's confusing. I know it's not Oxford, it's not Miami. I know it's very confusing. So welcome everybody. And so I want to talk to you just a little bit about the board that we were able to create as part of this study. And the first thing, why don't you go to the next slide, Rachel? The first thing I wanted you to think about is sort of, and you can go to the very next one. Perfect. Thank you. And so we want you to think about for yourself all of these different questions. So when we went to develop the board, this is what Jane Straker and I sat together and thought about. Who are the people that we know? Who could we partner with? And the two things we were tasked with was developing a rural research advisory board and a research advisory board comprised of, from either a community that represented a larger proportion of people of color or a community that was all people of color. And so We went to our data first. So as part of Scripps, we have our minimum data set data that we could go and identify providers with high proportions of minority residents. Or for example, maybe you're looking for younger residents. Maybe you're looking for residents of different groups, right? So see what data you might have available to help you identify those providers. And then think about also all of your colleagues that you could reach out to. We also reached out to ombudsmen and asked about providers that they might know who might be interested. They're in these environments. They know the providers, and so they might have ideas of ones that might be more receptive than others. Also, I wanted to start my timer so that I don't go over. And so those are some ideas. Think about the professional organizations. So for example, Leading Age and the American Healthcare Association all have state affiliates, and they are member organizations. So the providers are members with them. So those are just some ideas. Think about area senior centers, support groups, area agencies on aging, so more local areas. You can also think about service providers, for example, home and community-based service providers and case managers. So we have been able to sort of think about all of these groups that we've developed over time to help us identify a couple of bureaus. The one bureau that we developed was in a rural area, and that was with Vancrest of Van Wert, and you're going to hear from Janna in a few minutes about that. And that was somebody that we had a personal connection with. We were able to reach out to the administrator, who was also the grandson of the family who started all of the Vancrest nursing homes in Ohio. And so again, you're going to be off on a much better foot if you can build relationships, build from relationships you already have. Let's go to the next slide, please. Okay, so for this one, this is a publication that I just wanted to provide to you so that you can see. None of this is going to be earth-shattering to you, right? So you've got to, build those relationships, and you've got to establish the trust and be very clear, especially right now during COVID. You need to be crystal clear about what your needs are when you go make the ask to a provider about what you need. When we went to Vancrest, we said, here's what we need. We need about 6 to 8 of your residents who can participate in about an hour a month for the next, for 10 months of a particular year. And we're going to need your support in getting them to a central location where they can hear from a researcher and provide input to a researcher. We worked with them over several months to develop that capacity. We drove up the couple of hours to Van Wert and met with them in person so they could see that we were real people, and we heard their concerns. We listened to where they were nervous, right? So the residents were intrigued but nervous about providing support or providing input, and we wanted to encourage them and support them in doing that work. Some other ideas, again, is you could start off with developing a group charter, and there's many of the SAGE resources that help in that process. So for example, the bio sketches that we asked the members and the researchers to create and share with one another helped us learn about them and help them learn about us. So that helped in facilitating that trust. One other thing, let's see, I'm just trying to scan my notes. I think the other component that that's I don't think I learned a lot about in my graduate training was valuing contributions. And what I mean by that is closing the loop. So you go, you make the ask, you get some feedback, and you go away, and they never hear or see from you, see you again. And so making sure that you circle back and say, hey, thanks so much for your input. This is how we used your feedback to improve what we were doing. I just can't impress enough how important that is. All right, let's go to the next slide, please. Great, thank you. Okay, so some other ideas that have helped us is when we go to meet with providers of any sort, what matters to them? And for the Van Wert experience and the Vancrest of Van Wert experience, they were touched that we contacted them. They said, you know what, we're in a rural community. People don't reach out to us very much. They don't think about us very much. This makes us feel connected to something bigger. And so they came with a perspective that they were grateful that we reached out to them. I'll assure you that is not the kind of reception we typically receive from providers when we reach out. There's just a lot going on in provider communities. They're short-staffed. You guys all know the issues there. And so learning what matters to them and making sure that there's some mutual benefit. Here's what we'd like to do. What could we do for you? How does this either, support your staff or support your residents, or, give your community something to talk about? Start with those smaller asks to build up if you don't have a standing relationship with folks. And that helps you build a track record of success. They learn to trust you, and then you can ask for more things. And as I mentioned before, be very honest about the time and effort you're going to need from staff, because that is money. And it's crucial for you to try and estimate as best as you can how much time and energy you're going to need from the staff, of whoever those staff may be, to the residents as well. Communication is probably the biggest issue, right? Because you're going to be making multiple visits, you're going to be having multiple phone calls, multiple emails, you're going to be spending a lot more time than you think trying to reach out and reach these providers. Just persistence is what pays off here. And then think of this, as I mentioned, kind of coming back to those small asks, think about iterative work, right? And again, that helps you close the loop, build on it, and keep improving. Let's go to the next slide, please. Okay, so some things that have helped us is that when we reach out to folks, we reach out and explain why we need their input. And we explain why we can't possibly understand things the way they can. And so, again, reiterating that we don't know it all. Yes, we're researchers. Yes, we might be PhDs educated, but that doesn't mean that we know everything. And so coming at it from that humble perspective goes a long way. So I would encourage you to do that. I think probably the most important thing, though, was that as part of this study, we had gratuity built into our budget where we paid each research advisory board member, so the residents, $200 for their time, and we were able to pay the organization $1,000. That went a long way. And so I want you to think about your budgets and think about building in funds for those kinds of things. One of the examples that was extremely important is that it's very difficult for us to build in hosting or food into our budgets. However, if you can provide it to the organization and suggest that maybe they use it to bring in a meal so residents and staff can eat together, or maybe when you come that they could provide some food for the researchers and the residents to have some ability for that small talk, right? Just to get to know one another. That's super important that I would encourage you. It's sometimes difficult to pay staff directly. So some other things that we've done that have been equally met with joy is paying them to attend a conference, paying for their travel, having them come and present with us. Really, again, that's not a huge amount of money and it means a lot. So those are some ideas. Okay, and who do you want feedback from? So this really comes back to who are the individuals that you want to hear from and how can you facilitate their contributions? And I would say to you that we have included people with cognitive impairment, so do not just dismiss people with dementia as not being reliable enough to engage with. We have not found that to be the case. You might need to engage residents or guardians and families, and include staff at all levels, from maintenance and housekeeping all the way up. And then you're also going to need to plan for visual and or hearing impairments. So that might need to be some adaptive technology. Okay, let's go on to the final slide. And so the last few comments that I want to make is thinking about, again, these ideas, factors of engagement, the respect, discretion and confidentiality, extremely important in our rural bureau, because guess what? Everybody knows everybody in these smaller communities, and there's oftentimes family members working in these communities. So just being very conscientious about who you share information with, thinking about you can't rely on a reliable internet connection. When we were in process of a meeting with Vancrest one time, they lost power. And so again, we just had to work with them to reschedule. Transportation may be challenging. There might not be public transportation. There might not be cabs or Uber or Lyft. And so if you're trying to bring people to you, that could be expensive, and it could be time consuming for those individuals who have to travel to you. Think about, you know, education levels. Again, there might be lower income and lower education. They might be distrustful of outsiders coming in. And so think about who, again, you can partner with, who's trusted. Perhaps, again, as I mentioned, engaging a senior center, a church, or other trusted organization as a meeting host. And if you can hire individuals who represent the people you want to talk to, another really good strategy. So let me stop there because I know I'm out of time. Again, thank you all for your attention. I'm happy to answer any questions by email or any other way, and I'll turn it back to Rachel.
Thank you so much, Katie, for that presentation. I really appreciate all your insights. And from just listening to Katie's presentation, we can see what are some of the characteristics of academic partners that make these partnerships successful. For example, multiple researchers are interested. Katie wasn't going it alone. She had Jane Straker along with her. And not only for the building of the partnership, but that you have other researchers involved later on who are willing and excited about presenting to your SAGE model board. But also because it takes time to build that relationship, that trusting and reciprocal relationship, and on one individual researcher, that can be a burden. Having pre-existing relationships with nearby and even apparently some far-flung providers helps, because not only do you have this experience in your background, but the groundwork has been laid so you're not starting out from scratch. Having leadership support for this effort, this can be time consuming, so it's helpful to, if the leaders in your academic department are supportive of that, and share your understanding that it will lead to better research, and also understanding the value of having all the voices at the table. It helps if the work of creating a SAGE model board aligns with the mission of your department, that collaboration already exists between and within the academic community, as well as having community-based priorities for engaging and collaborating with community partners. And these were attributes that we looked for in our previous project when we were looking to expand our model to new locations. So now that we've talked about academic partners and their work, I'd like to switch gears and talk about provider partners. As researchers, we've all worked with providers of various services to older adults, but let's see where that experience lies. Christy, can you launch the poll, please? Great, so let's take a few moments where you can choose more than one answer of the providers you've partnered with and see where that background lies. I see we've got about 25% voting, so we'll wait a few more moments so everyone can get their votes in. This is the audience participation portion of our program. I see that right now community-based services is really far in the lead, with about 70% of people having worked with community-based services organizations. I'll give it another moment or two if anyone hasn't had a chance to vote yet. And then Christy, if you could share the results. Yeah, so you can see by far, people are really have a lot more experience in community-based services than elsewhere. But a close second and over 50% have also worked in nursing homes. And maybe during the question and answer period, we can hear from the folks who are working with other settings that we hadn't thought about in our poll. I'm going to close that, and moving along, one of the things we wanted to share is this is a screenshot from one of the SAGE resources that actually Katie and Jane created to help clarify what the roles are of providers and members. And this then can be used for new SAGE model boards when you're after partnership. So what do we mean by a provider partner? The SAGE model is flexible and can be used in a range of partnerships. These are the provider partners from the SAGEs in Every Setting project, and not everyone is a nursing home. Katie gave us an example of Vancrest of Van Wert, and we will hear from Janna, who's the activities director there, in a little while. And they provide both assisted living and skilled nursing. And here are some other examples. As I mentioned, the Lieberman Center for Health and Rehabilitation, that is part of CJE Senior Life, where we also have a research department, and where one member of our staff always has a university affiliation. There's the Jewish Home of Eastern Pennsylvania. They are a standalone nursing home. Hebrew Senior Life provides a spectrum of care and housing facilities and services very broadly in the Cambridge and Boston area. And one of our academic partners was working with them to create a SAGE model board and had established that partnership, but unfortunately, due to COVID, the board didn't quite get off the ground yet. We have, as I mentioned previously when talking about academic partners, the Meslem Center, which does research on neurology and Alzheimer's disease, but the board itself was comprised of people in the community who had been diagnosed with dementia, and the facilitator and the academic partner there was a social worker who was also a researcher and wanted to start this group with these people who are still living in the community but also had dementia. Self-help provides educational and social opportunities for adults in the community, and with their virtual senior center, their primary role was actually to recruit and to provide a platform for a virtual board where all the people were stay-at-home older adults receiving services in their home, and CJE was the academic partner. And interestingly, the current facilitator, who started out as a grad student working with CJE, is now on the faculty of a university. So roles may evolve as your SAGE model board continues to operate, and hypothetically, the academic host could change. So what are the characteristics of a good provider partner? Katie really went through this very well, and I think that example is very helpful, but their openness, the provider has to have an openness to the SAGE model, to the mission of a SAGE model board, meaning they value person-centered care and are interested in innovative research. It's helpful to have an on-site champion who can really take the lead for the provider in establishing that partnership. Having enough staff time to do the work, to take the time to recruit the members, to attend the meetings, to do the logistics, and that the provider really has a strength-based approach to older adults, focusing on what the older adults can do, rather than viewing them through a lens of functional limitations. So what happens, what's the role of a provider partner then? There are four main duties. The first is to identify a facilitator, and Rebecca will talk about the facilitator in more detail in a moment. The provider recruits the members because they're the ones who know their population, and in conjunction with the academic partner, they will set up training for the members, and they will also coordinate the logistics with presenting researchers. And those last two bullet points we're going to cover more in our February webinar. Next, I'd like to turn it over to my colleague, Rebecca Berman, who is also a research scientist at the Leonard Shanfield Research Institute at CJE, and she's going to discuss the facilitator role in more depth. Rebecca?
Yes, thank you, Rachel, so much for that introduction. I'm going to talk a little bit about the facilitator role, but I want to say the first thing that we have to realize about facilitators is that they're really a liaison. They are the person that interfaces between the provider staff, the academic partners, the members of the research advisory board, and the researchers who come to present to that board. So first of all, their role is to collaborate. They collaborate in the planning phase, as Katie mentioned, building relationships with the academic partners, building relationships with the members, and establishing those roles, especially taking into account what they are able to do. So really they're involved in how to start a research advisory board and with any other provider staff who are involved. They also collaborate in decisions about how that board will operate with members. So what will they do? Will they have a mission? Will they have a vision? Do they have some values they want to convey? The facilitator will assist the members in creating their own bio sketches. Finally, they will collaborate in providing input to academic partners for the purpose of process evaluation, and sometimes also assist with collecting data. The second major role is to coordinate. That really involves recruiting the members, orienting them to the concept of a research advisory board, assisting with or even providing training on basic research concepts. We have had some facilitators who felt they had the capacity to do that. Dealing with meeting logistics, the scheduling, the finding the locations, getting members to meeting, which can sometimes be time consuming because they may be in wheelchairs or have other issues that make it difficult for them to get there. Setting up equipment for the online participation with researchers, and communicating with the staff who support all the members so that there aren't conflicts with therapy appointments or medication schedules or things like that, so that the staff are also aware that this is an important activity for the members. Finally, the most important thing they do is facilitate. So they support the members in their ability to express relevant personal experiences and in their ability to understand each other and the researchers. So in a way, the facilitator becomes the model for how to respect different perspectives and how to keep meetings on task, meaning keeping it focused on the research topic at hand. And we'll talk a lot more about facilitation strategies in the next webinar. Next slide, please. Thank you. So what kinds of facilitators did we have? We had facilitators who were provider staff. You'll hear from an activities director shortly. That will be Janna. We had facilitators who were volunteers. We tended to get people who had a background in social work, and that was an interesting pattern that we've had. And we, as researchers, sometimes also facilitated our staff, and I think also some of our academic partners have co-facilitated. And we've had student interns at both the graduate and undergraduate level. What's common about all of them is they made a clear commitment to do this kind of work. There needs to be a commitment because the members need to be able to establish rapport with the facilitator, build relationships, and there has to be some continuity over time in who's coming and convening these meetings. Co-facilitation we found to be a very useful strategy. It's not possible in all settings, but it's ideal. That allows for more than one volunteer or staff person to do the work. And that means co-facilitators can be used for shorter periods of time, such as 2 to 3 months, which can then accommodate the use of student interns. Next slide, please. So how do we train the facilitators? Well, it really depends on what they come to the table with. Each of them had different strengths and different gaps or needs for training. So we had a fair number of people, provider staff and volunteers, who were familiar with potential members or members. So they didn't need to be oriented to the setting as much as other people did. But if that is an area of need, then we have to add some training for facilitators to be able to work with staff, to take training that the provider requires for volunteers or interns and things like that, maybe some more mentoring and observation. Some people come to the table with lots of experience in long-term care settings or working with older people, which is wonderful. And then we don't have to do as much work in that area for training. But if it is an area of need, then we might have to do more mentoring or connect them with provider staff or others to help them build those initial relationships with the members and to help with recruitment. Experience in other areas, such as facilitating groups, has been very valuable. What's interesting, though, is the people that we have had in facilitation roles have often facilitated other types of groups, like an art therapy group, a support group, some kind of activity or a discussion group. So one of the things that we have to do is emphasize that this is a unique activity, a unique group, and that the dialogue and facilitating that dialogue is different. And it really involves different aspects, which we'll talk more about in the next webinar. Some people came to the table with very relevant knowledge in areas such as person-centered care, knowing a lot about aging, having studied that, or having a lot of research background or knowledge. That's also wonderful, but sometimes we needed to build in more time for them to observe existing research advisory boards or talk to existing facilitators or co-facilitate so that they became familiar with how this particular setting is different from what they know. One of the interesting issues is that if we come to the table with a lot of research experience, you may also tend to use what I call research speak. So that isn't necessarily an asset. So one of the wonderful things about the training that we have developed for members that pertains to research concepts and processes can also help orient the facilitator in how to speak about research in plain language. So there's resources that we have on our website that pertain to that, and we'll talk about that more in the future webinars. Okay, I'm going to hand it back to Rachel now. Thank you.
Thank you, Rebecca. That was very helpful. The most critical initial responsibility of the facilitator from the outset is member recruitment. This is a slide from our resources that introduces potential members to why become members. But thinking about who should be on your board, about 5 to 10 people. You want to think about a mix of personalities and what voices you want to include, whether it's a mix of genders or ages or backgrounds. As Katie mentioned, mental competency, we can have people with cognitive impairment who are able to participate and give back, so that shouldn't be a barrier. But also people who are looking for stimulating activities in their setting, who are outspoken, who are thoughtful, who are interested in making a contribution. Thinking about the fact that no one person can represent the group. So you want to define your expertise differently. What skills and knowledge and life experiences can they bring to the table? Differences in ethnicity and race, perhaps differences in religion, differences in geographic locations will come from before they came to the setting they're in now. Are they Medicaid or private pay? And also understanding who individuals can speak for and who they can represent, because no one person can represent an entire heterogeneous group. And finally, identifying the missing voices who aren't at the table, who aren't usually at the table, and figuring out ways to include them. And in recognizing also that nobody wears one hat, and one person can speak from more than one perspective, depending on the setting and context. So someone who is a resident of a nursing home right now may have formerly been a researcher or an advocate or a caregiver, or someone who is active in the community as a community representative. What hats are they wearing now? And what does this mean for the information that I'm receiving in getting feedback from the group? For example, we have members who had experience living in assisted living before they came to long-term care, and their views and comparisons between those experiences is often very helpful as well. Here is another example from the SAGE resources. That's a two-sided brochure, really, that can also be used to help recruit members. So how do you approach a potential member? I think the key that we have found is trust in the recruiter or the facilitator. Oftentimes, this is a known staff member in the provider partner. For the Lieberman Bureau, this was our art therapist. And one of our members, when talking about how she was recruited, said about the art therapist, quote, "She was very engaging and very likable. Everybody liked her. I couldn't imagine her steering anybody wrong. I figured if she recommended it, I'd better check it out." So how do you go about and do that? You meet with the resident in their room and have a conversation with them. You can announce it in another group event or meeting, such as a resident council or an art therapy group, or maybe a small book group discussion. Bring it up in casual conversation. Hey, there's this new project we're starting. We're starting this research advisory board. Have the researchers, have the academic partners come visit in person. Katie mentioned how critical that was for the Vancrest folks to see that investment, and with the staff member, with the provider partner, have the researcher introduce the idea. And then finally, once you're established, have members ask other members to invite someone. There's that trusting relationship. So talking with our board, Sharon was invited by Nancy, but then Sharon told Linda and Fern told Julia, and Julia told David. And that's how the board can really sustain itself and have a group of diverse voices and have that interconnectedness as well. Both Rebecca and Katie have mentioned the BioSketch. This is an example, a screenshot from our SAGE resources of the interview guide that we use to create the BioSketches of new members. And BioSketches are created for everyone, including the facilitator, the academic partners, and the visiting researchers. It's not your typical academic BioSketch with your publications and awards and presentations. The act of creating the BioSketch helps further develop the relationship between the facilitator and the members. And when the academic partners and researchers share theirs when they visit, this helps equalize the power dynamic that may exist beforehand. So it makes the members feel more comfortable giving their input. And this is just a quick example of Mariana's BioSketch as she shared her perspective on being recruited. And it really finds commonalities between researchers and older adult members and increases their comfort level in giving feedback. So what motivates members to be part of the research advisory board? You have to make it matter. Listen to all the participants, validate their ideas and the value of their role on the board. And then, as Katie mentioned, close the loop. Keep them posted about how their input was received and used. And you can do that either by just reporting back to them as the facilitator or inviting researchers to come back and say, okay, now I'm in this stage on this research project, or I finished and it's led me to this new research project. Can you give me more feedback? And also thinking through the incentives, gift cards, which operate as remuneration for people's time and effort in providing this valuable feedback. Having the social interaction, especially during COVID, if you're meeting virtually, still having that ability to see people when people are so isolated right now. The peer support from their fellow members, access to information about new and innovative research, the opportunity to improve services, applying research that is coming out now, but also understanding that research is a long process and their feedback now helps them to make things better in the future. And that is invaluable to people. And just recognizing the time and commitment that they are making to be part of this board. So after all the members are recruited, and we'll focus on this more in the next webinar, is initiating a sense of ownership. So they make the board really their own, both through the development of their bios, but choosing a name. Not everyone has to be the Bureau of SAGES. Using the mission and values of other boards as a jumping off point to determine what their mission and values are, what their research priorities are. As part of the training, planning a study and practicing, if they would like, thinking like a researcher, but also planning what those meeting details are. How often are they going to meet? How long will they meet? Will they meet regardless of whether a researcher is visiting or not? And finally, the incentives, like serving food at the meeting, maybe having membership cards or t-shirts, things that develop their own sense of ownership. And finally, I'd like to end with Janna Wireman, who worked with Katie and Jane from Miami of Ohio, and she's the facilitator of the Vancrest Research Advisory Group. She couldn't be with us in person today, so she gave us some time and her reflections on what it was like building this partnership.
Hello, my name is Janna Wireman. I'm an activities director at Vancrest Healthcare Center, where I've been currently at for 23 years. It was a great opportunity to work with the researchers to create this advisory board. To be able to reach out and to network with others, to have the opportunity to see growth in the research of those who are in the aged population, and even those who are just currently residing in long-term care, whether they're aged or whether they're younger and due to health influences need to be at a long-term care facility. What made the process work, I think, people just being willing to participate, willing to spend time, willing to be encouraged by what was going to happen, be open to possibilities and wherever things would go. I think the most challenging thing was when we had to do things more online with the residents. It's just because a lot of them are unsure, and due to some visual and hearing loss there for them, it was a little more difficult for them to participate online. To just be excited about what you're bringing to the table, to be excited about the opportunity, and just to continue to give reassurance that their voice is heard and it's valued. I think, there's just a lot of uncertainty and assuredness on both parts of the researcher and those who are being asked to develop an advisory board. So I think with both parties, just encouraging one another and just reassuring that that this is a very good opportunity and one that will be have a positive impact. It was neat to be able to pair with researchers in the field of this population. What an opportunity. We, in all the years I've been here, we've never had an opportunity like that. And I'm a firm believer when an opportunity comes knocking your door to take a look at that. And I think, with just that knock of opportunity for someone to say, hey, we would be interested in hearing what you all think about what we're researching, what we're doing. I think that's what got me excited and what made the residents excited about doing this opportunity as well. First of all, to recruit residents to be a part of the advisory board, first and foremost, you have to be excited about it. Because that's what really it seems to draw a lot of the residents. If you are excited about what you're approaching them with, what you want them to be, to participate in. And I think just reassuring them that they do have a voice, that they do have a valued opinion, and that people can learn something from their experience and their life. I think whenever you put together a group of research advisory board members, you want as much diversity as possible. So I was looking at, okay, I want a good mix of males and females. I want a good mix of ages, of backgrounds. So I try to select, we have some of our residents here are in their 40s, 50s. So I try to choose some younger people, and I had in the middle, if you will, so 70s and 80s. And then I even had a 100-year-old. So I wanted something that was diversified and just showed a variety. And then I also had people who perhaps were self-employed in their professions, some people who, worked in other professions, maybe even some housewives. So people with different perspectives on what they wanted to bring to the table. I think it's always interesting, and it's always a plus when you can have that. So we did and I forget the technical term, so I'm sorry about that, but we did where it was very much interesting to do those interview pages. That was a big help, feeling like they could have a connection and make up one of their own, and to do the outline. And I think, just really having a well-rounded of ages, of people and backgrounds was very important. The biggest challenge in recruiting members was many of the residents said, well, I really don't have anything that would be worthwhile to add, so it was their really lack of confidence of anything to be able to give or that would be anything of value. So I really had to encourage them that, that their opinion mattered and was valued in all of this, and that there was really no wrong answers. It was just what their opinion was. I think many times they were hesitant or maybe unsure of, would I give the wrong answer or not provide the right thing that they want. When you make up an advisory board, I know it was important for many people to do nursing home residents and assisted living residents. I wasn't real sure about the importance of having that nursing home versus assisted living. At our facility, they're pretty much one and the same. We have some assisted living folks that might be a little bit more independent, but we also have that in the nursing home. The biggest thing about nursing home residents taking members from there is they tend to have more doctor's appointments. So it was hard to have them included in the advisory board due to maybe a lot of their appointments or things they had going on with health-wise. It was nice to have Katie and Jane come out. I think that was pinnacle for us, to have them come and talk with the people that, I selected to be a part of the advisory board, so that they could see firsthand and talk to someone from Miami University about what this was going to entail, what this process was going to look like, any questions they might have had about what happens to this research and how do we get this research and how does this all start. And so I think that was very pinnacle, having them come out personally and talk with our residents. We were very fortunate that our administrator here was, we met together when the opportunity came and said, hey, what do you think? And we both agreed this would be a wonderful opportunity. So therefore, that percent was there, 100%, that support. So I think with the acknowledgement going into it that this would be something that the administrator or the executor of your facility would agree with, that this would be a project that would be worthy and they would support, that is vital, I think. So that, therefore me having the time to devote to it, it was acceptable and valued. And that also that when I needed to go to our administrator for assistance, perhaps, and getting online things going, or I had a question about whatever it was, or support, I need to take the time to do this or that, it was given. So I think, having that support and that communication with your administrator, executor of your facility is crucial. I'll speak on the two-part one. For me personally, what an opportunity. I'm always looking for new opportunities, because when you've been at a place for so long, you just want that, I think, to keep growing, to keep evolving. So I was excited about the opportunity and the doors that this would open. And I'm still encouraged by the doors that this could potentially open for Vancrest, for the facility here. we are we're in a small town of Van Wert, Ohio. And, like I said at the beginning, opportunity maybe doesn't always come knocking on the door as quickly as maybe a larger facility in a larger city. And so I was very happy to have the opportunity to be sought to be a participant in this. And I look forward to the doors that it will potentially have for Vancrest in the future. So I think, as far as Vancrest, I think it's all left to be unknown yet. And I'm excited about what opportunity, perhaps in the future, that the research that was already done or that will be done will have an effect of future research.
So I just want to say again how grateful we were to have Janna spend some time talking about her experience, because I think that's really invaluable. And I'm just going to wrap this up quickly because I see we've gone long on time and I want to make sure we have time for Q&A. We have February 11th and March 11th are our next two webinars, so make sure you save the date for those. And you have already registered when you registered for today. So finally, I'd like to open it up for Q&A, and in the chat, you will see the evaluation, a link to the evaluation survey, as well as a link to the SAGE resource training page, where we will be putting this video of the webinar when we're done, and you can watch it again or share it with your colleagues. So I'd like to open it up for questions. If anyone has any questions, you can raise your hand or throw it in the chat. Well, why don't I ask, oh, yes, and Katie put her name, her email address also in the chat. So if you want to reach out to her directly, you can do that as well. Mary Rose Janovich, I'm hoping I'm saying that correctly, asks how much we pay the patient advisors and facilitators. So I think that varies from group to group. Our facilitators are volunteers or do it as part of their staff time. And I believe, Katie, you mentioned that for Vancrest, that part of each SAGE member was paid about $200. Is that right?
Correct.
Over the course of the year?
Correct. Each member received $200 and they were paid at the end of October. So we met like May, June, July, August, September, October, and they received that payment at the end of the last session we asked them to participate in, and they were much appreciative. They used a lot of them used it for gifts for holiday presents. And then we gave the organization $1,000. And they used that, they used some of that to buy technology for us to do virtual meetings.
And we did something similar, about the same amount of money in stages. And also we used gift cards to make it easier. And you have to be a little bit careful when people are receiving benefits that you don't exceed what their monthly maximum is. In terms of resource capacity, Sarah Dice asks, did research teams operating a SAGE model have designated staff to coordinate, or the researchers were primarily facilitating from the academic partner side? I think if you're talking about finding researchers who are going to, in terms of the beginning building, that was the PIs and co-Is who are primarily facilitating. And then as it's going, the PIs are the ones who are responsible for helping connect the provider partner with researchers. And I think, Katie, you could also talk to that as well, about what support you had, or that it was really you and Jane who were doing all of it.
Correct. We didn't have any other support. It was just the two of us, our time, reaching out. We would make the travel. We did have some budget for mileage to drive. Of course, this was pre-COVID, so we could go. And so, but it was mostly just, we just had a little bit of reimbursement for our time, and we had some mileage.
And then there's, and I think that varies too. I think some of it is word of mouth, is that researchers telling other researchers that they presented, but there is some time in building that network of having researchers come and get feedback. Rebecca, you want to speak to that?
I'll add that as researchers came to the advisory boards to present their work, many of them took on a sort of co-facilitation role in the discussions. That's all I would add. But they sent the meeting invitation, like, so that the provider didn't have to set up the meeting virtually.
Right. Yeah, because not everyone has WebEx or Zoom, so relying on that is helpful. Someone's asked whether Zoom is available. So right now, Lieberman is doing Zoom meetings. So if you do want to present to a SAGE model board, you can contact me. And also the Virtual Senior Center, which is people living in the community, are also still meeting right now. There's a question, did you specifically recruit participants with cognitive impairment or just not exclude them? And what participation support you had? So we did have a board completely made up of people who were recently diagnosed with dementia. And I certainly, different approaches to doing that. And so that was specifically including them and specifically recruited. And then in the other boards, we didn't specifically exclude people if they had cognitive impairments, but finding different ways to word questions and get feedback. Rebecca?
Yeah, and the way we do the training and the way we facilitate that dialogue focuses on repeating things anyway, so that you never ask anybody to remember anything, regardless of whether they're able to. It's just a different way of having dialogue that you repeat, reiterate, practice, and that's how we did everything pretty much.
Mm-hmm.
We're out of time.
We're out of time. If you want to stay, I can stay a little longer. I don't want to rope anyone else into that, but if you have a few more questions. And I'd also say other impairments like hearing impairments. We had one person who was really hard of hearing, and what we did to manage her participation is someone sat next to her and did live closed captioning, typing on a laptop in very large font so she could follow the conversation. So there are a lot of adaptations you can use. Funding sources, our funding ranges. Our funding came from PCORI. And again, a couple $1,000, $1,500 to $2,000 is helpful to help the provider purchase the technology and staff support, and also to give those incentives to members. But certainly a range is possible, and I wouldn't say there's one set funding. Go ahead, Rebecca.
That person may be asking more about what it takes from like the team, the academic partners, to build it. Like, what was the funding range for actually starting this from the ground up? I'm not sure if that's what the intent of the question was.
Yeah, I do want to clarify.
Yeah, that's exactly right. Thank you, Rebecca.
Okay. We can talk more about that probably offline if you want, because we're out of time. We can definitely shoot us an email and we can talk.
Yeah,
Will do. Thank you.
you're welcome. Okay, well, thank you so much, everybody, for attending. Thank you so much, Katie, for joining us. We really appreciate working with you and hearing your perspective. And I look forward to seeing everybody in February. We will send out a link to the webinar recording, and please do fill out your surveys. That will really help us plan for the next one as well.
Thank you so much.
Thank you, everybody.